present this case, Raman gave a great talk in terms of data, so you guys have all that. But my main goal for you guys in terms of presenting this case is the most important that PK taught me during my fellowship was algorithms. So you have to have an algorithm or an approach to every lesion that you see, whether it be simple or complex. So this is going to be an interactive talk a little bit, and please don't feel like there's any wrong answers. If you've been married, you know that you're probably always wrong. So, but you get through it. So here we go. So this is a patient of mine that is 54-year-old female, hypertension, hyperlipidemia, tobacco use, has had a stent to the left SFA in the past, has limiting claudication, and but no ulcers or rest pain. You can see the past medical history and so on and so forth, appropriate medications, decreased pulses on the left. ABI on the left is 0.59 and on the right is 0.84. So this is our angiogram. And what you can see is you have catheters in the abdominal aorta. You can see that there's some moderate disease in the right common iliac, and the left looks fairly decent. Here's the next. How do I go to the next one? Okay. So here's the runoff, and I'm going to show this twice so that you guys can understand. So you can see some disease in the SFA. And then you have an occlusion at the stent segment right there in the mid portion of the SFA with distal reconstitution at the distal segment of the SFA, followed by popliteal that isn't no significant disease, and then a 3-vessel runoff essentially. And then this is your more selected pictures. Proximal SFA has disease, the mid SFA is occluded within the stent, the distal SFA reconstitutes. Popliteal is okay, and then you have infrapopliteal 3-vessel runoff, okay? All right, so now we talked about algorithms, right? So I'm just gonna go around just please speak up, okay? So we'll go one step at a time. You're not gonna be addressing all these. So access, you see this lesion, you have an occlusion, you have severe proximal disease, mid-occlusion, distal. So what is the first thought in terms of access? So someone throw out what size sheath, how you're going to get up and over. Go ahead. Contralateral, good. Okay.
Why 7, not 6? Okay. But okay, that's one. Well, I think you got to choose your sheath per your device, right? So if you want to go with a Rotorex device, if you want to go with a Jetstream, which is also indicated in ISR, if you want to go with a larger laser, especially the rotational laser that I know we didn't go over that data, you would have to choose a bigger sheet. So what he means by algorithms, when you see the lesion, you plan it, just like you do a coronary bifurcation if you're a cardiologist, or you do an aneurysm when you're a surgeon, or radiology if you're coiling something. You plan that before you go, and that plan is going to be part of your equipment. I think that's what Dr. Majeed wants you to think about. Okay, good. You're not wrong. Just saying that's important.
Great. Okay. So great point. Okay, access. So like I said, as you get more and more experienced, this all comes naturally, but I always used to write these steps down in terms of when I was a fellow and to understand exactly what I went through. So the second step is lesion crossing. So we'll go through the pictures, but I just want to kind of get an idea in terms of what people are thinking. So you've got 7 French, let's say you've got a 7 French 45 over. How are you going to cross this lesion? You guys saw this proximal disease, occlusion, and distal reconstitution.
Wire catheter combination.
Okay. What wire, what catheter? 014, 018, 035. Okay.
I'll start with 014 wire.
014 wire. Okay. Anyone else?
How about on that side of the room? Anyone else? The gentleman scratching his head. I got you. That means you're thinking.
Yeah.
So what wire you think? You agree with 014, 018? Okay.
Replay the pictures. Can someone go back? I don't know how to go back on this. So that's your prox. This is your mid that's occluded within the stent. And there's your distal reconstitution. Okay, so 014 with an 035 catheter. Anyone else? There's no wrong answer, like I said. It's just.
Antegrade?
Antegrade access.
Okay. You have space.
Hit
That's 100% reasonable.
Okay, all right.
Just add a time frame like a burn state just to increase your support from the beginning.
Right.
Maybe a CXI with the command or whatever wire you use, just so you don't have to add that secondary. You just try it first without. I would probably just put a 5-minute burn state from the beginning.
Okay, good. Okay.
What'd
So,
you do?
so most people are saying 014, which is very reasonable. 018, I mean, I think that all are reasonable. Even an 035 glide is reasonable in this situation.
Concerned about the iliac, crossing over with this. Check a gradient or okay, issue.
I wasn't at that time. No, I think that we crossed over and there wasn't much of an issue. We used a supercore wire to cross over, used a 45 centimeter sheath to cross over, but I wasn't concerned. Okay, so all right, so wire, we talked about wire. So what's the next? So what is filter or not filter in this? So you guys had a great data talk here. So filter or not filter? No filter. Okay. Filter. Raise your hands for filter. All right, no filter. Okay, so most people want to do a filter. Okay, all right. So what's the initial therapy? So is it, so I'll give you some options. Is it PTA? Is it going to be thrombectomy? Is it going to be atherectomy? IVS, okay. I'm not unreasonable. Anything else? Say that again?
Laser.
Laser, okay. Yep, great data for laser, excellent. Anybody want to do thrombectomy in this? Considering we heard that most of these in-stent restenotic lesions have some level of thrombus. You want to do thrombectomy? Yeah. So, okay, good. All right, okay, so that's our initial therapy, and then definitive therapy we'll talk about. Okay, so this is how I used to write these down. So these are the procedural steps that I used to go through. So again, if you get anything out of this, understand that you have to come up with these algorithms for these lesions to be successful. So, groin access, again, crossing catheters. We used actually a glide wire with an 035 system. Filter, again, we did use filter because there is obviously concern for thrombus that you just heard from Raman. Mechanical thrombectomy is what we talked about, followed by laser. And then our plan was drug-coated therapy, drug-coated balloon therapy, and then possible stenting of the proximal segment. So let's go through this. All right, so this is our mechanical thrombectomy. This is our angiojet catheter, so we're using that. And so after the angiojet, this is what you get.
So you can see the amount of, and what you need to know is how the wire crosses.
Yeah.
So if you have a lot of difficulty crossing the wire, but if your 035 wire flies down, then you know that likely you're going to have some thrombus. With the ISR, you may also have a proximal cap that's stenotic, and then a distal cap that's obviously occlusive. But in the mid segment, you can get a collateral from your profunda, which is filling, which may leave what we call loosely sludge inside that stent. So you may fight through the proximal cap. Mid may be very fast, distal may be a fight, but in your mind you have to know that that mid segment is. That's why every part of the procedure you have to learn from and react to what you're getting your feedback.
Right, so we have significant, looks like disease and thrombus here. So at that point, we actually did a laser, right? So here you can see we did a laser that debulks, that the ultraviolet light basically debulks the thrombus and the intimal hyperplasia. So after that, we get this. Okay, so we're getting some increased luminal gain here. My time is getting shorter. But you can still see there's a lot of disease up here, right? So at that point, we did PTA of the proximal segment and DCB of the in-stent segment. So we got that. So now what are we seeing? This is an important part. So we've done 3 therapies. We've done angiojet, we have done laser, and we've done PTA. So what's going on here? Oh, say that again? Thrombus. Good.
Embolization.
Okay, distal embolization. So I'll give you a better picture of this. Yeah. Okay, so this is what we see. So how are we going to deal with this? Yep. Okay.
So how do you deal with it?
How do you deal with it? This is a PK special. So he has taught me a great technique in terms of and he does this all the time. So I want him to talk to you about this technique that he does.
Yeah, so basically you go in with a catheter. You don't have, you can use a penumbra, which is very expensive, or you can use a multi-purpose. For the sake of penumbra, since they're here, it's approved to do it, so use a penumbra. And what I would suggest is that you use 2 wires. If the filter is, so remember, you have to look at the filter and you have to see where the column stops. So if there is a column in front of where your filter is, that means all that is debris material. So you have to start aspirating above, coming down. But if it's all inside your filter like this one, then what you can do is you can go down into the filter and do it. So you can do 2 things. One, you have to understand how the filter works. So if you aspirate on the bare wire, the filter may close and you may embolize. But you're aspirating, but there's still a risk of embolization. Second, you can take a second wire, put it inside the filter, track the aspiration device like a penumbra down into the filter and aspirate the filter. So the filter will not close. So the advantage of an Abbott Embershield versus a Medtronic device is that you're not going to lose wire access. So you can actually aspirate the device and actually aspirate the filter as you come out. Well, so if you fill the filter, it's like a carotid intervention, right? You could spill. Unlike a carotid, thank goodness you're not going to get a stroke here, but at the same time, you could embolize and really create a major problem down below. So you have to be able to manage the filter as well as aspirate the filter. You cannot just capture the filter if it's full of clot. You will embolize.
Yep, it's going to overspill. Go ahead.
I mean, I don't know. Tak is here. He's a very experienced guy. Tak, do you ever do the lytics in this? If you have a filter that's full, or you just aspirate like we do? Yeah. So I think the risk of lytics is, it can always bleed, and the idea with these large bore sheet, I mean, not that 7 is large, but it's not small either. And, these PAD patients, we don't lyse unless we really have to, because you can manage it without lytics. But is it wrong? Likely not.
Okay. All right. Okay, we're almost done. So at that point, we did exactly that. We actually did a penumbra and aspirated the filter, pulled the filter out, and you can see that this is our result. Where we got good flow down to the foot, and then we ended up stenting the proximal portion of the SFA with a Zilver stent, and then we had great flow down there. Okay,
All right.
All right.
Great job.
Thank you so much.
Thank you.